Welcome back to the Deep Dive. Our mission here is to give you that ultimate shortcut to being well-informed. We dive into complex source material so you don't have to, and today we're tackling something we've all experienced. Fever. You feel awful, the thermometer confirms it, and then comes the big question, do I need medication? Or do I just need to rest?
It's the classic dilemma.
Exactly. And our source today is this incredible clinical quick guide. It's the kind of thing used in a busy outpatient department, an OPD. It's basically the checklist doctors use to tell a viral fever from a bacterial one. And that distinction is, well, it's everything when it comes to using antibiotics correctly.
It really is. This guide gives us the decision tree.
Yeah.
It shows how a doctor moves beyond just, I feel sick, to looking at objective, measurable signs. It's a synthesis of what you tell them and what they can actually measure. Things like timing, physical signs, and most importantly, the lab results.
Right, turning a feeling into a diagnosis. Okay, let's unpack this. We're going to start at the very beginning, that initial assessment. What are the first sort of non-negotiable signs that start pushing a sickness into one category or the other?
So the first clue is always about onset. How quickly did this thing hit you? Our guide really emphasizes that viral fevers, they tend to have a gradual onset.
So you feel a bit off one day, a little worse the next. It sort of builds up.
Precisely. A slow creep. A bacterial fever, on the other hand, is often sudden. It hits you acutely. People will say it came out of nowhere, just knocked them off their feet.
That distinction is fascinating, the slow creep versus the sudden punch. But what about duration? If you're at home wondering, how long is this supposed to last?
Duration is a massive flag, a huge one. Most viral fevers, they have a pretty clear timeline. They generally resolve within, say, 3 to 5 days.
Okay, 3 to 5 days.
Right. They peak, and then they start to fade. But if that fever is persistent, if it's lasting more than 5 days...
So that's the threshold.
That's the threshold. According to the source, that's when a clinician has to start thinking, okay, this might be bacterial. We need to dig deeper.
So day 6 changes the entire conversation. Let's talk about the heat itself, the temperature. Are there, specific number cutoffs?
There absolutely are. The guide gives us clear numerical markers. A viral fever will usually stay in the low to moderate range.
Which is what, exactly?
Typically under 102 degrees Fahrenheit, so around 38.9 Celsius. It's uncomfortable, for sure, but it's usually manageable.
And a bacterial fever?
That's when you see the numbers shoot up, often over 103 Fahrenheit. And critically, it often comes with those violent shaking chills.
Rigors, right?
Exactly, rigors. That high heat plus the rigors, that's a high alert sign.
So the number on the thermometer is a real piece of data. Okay, but let's move beyond that. How do we tell the difference between feeling generally miserable all over and having a very specific problem?
That's a key distinction. For viral infections, the symptoms are general. They're systemic.
The whole body experience.
Yes. Think about it. Body ache, fatigue, a generalized sore throat, cough, cold. It feels like your entire system is just under attack.
And the bacterial picture is the opposite. The guide says the symptoms are localized.
Precisely. Bacterial infections love to pick one spot and set up camp. So we're looking for a clear target. Things like, visible pus on the tonsils.
Yeah.
Or really sharp ear pain.
Right. You can point right to it.
Exactly. Or that burning sensation when you urinate, burning micturition, which points to a UTI, or a really thick, productive cough that suggests something's going on in the lungs. That link to a specific site is crucial.
The body is literally showing you where the fight is. That's a great way to put it. Okay, now let's shift from what you tell the doctor to what the doctor actually sees and feels, the physical exam.
Right. And this is where we get one of the most significant, though I guess you'd say qualitative distinctions, the toxic look.
The toxic look, what does that mean?
It sounds dramatic, but it's very effective. A patient with a viral illness, even with a fever, usually looks relatively mild. They're uncomfortable, but they're still responsive. They have some energy.
Okay.
The patient with a bacterial infection, especially a serious one, often looks, toxic, weak. They might seem lethargic, dehydrated, just acutely distressed. That general appearance is a major indicator.
So beyond just that first glance, what are the physical things a doctor is actually checking for?
The guide points to lymph nodes. In a viral illness, they might be a little swollen, sure, but they're typically mild and they aren't tender.
And bacterial.
If there's a local bacterial infection, say in the throat, those nearby nodes become enlarged and distinctly tender when you press on them. They feel angry.
Okay, that makes sense.
Yeah.
What about listening to your chest or pressing on your abdomen?
Yes. With viral fevers, the exam is usually pretty unremarkable. There's no circle tenderness, no one spot that's exquisitely painful, no organomegaly, meaning the liver and spleen aren't swollen. But bacterial infections, they often leave clues, focal signs.
For example,
The doctor listens to your chest and hears crepitations, that little crackling sound. That points right toward a bacterial pneumonia. Or they find that specific tenderness, or see those exudates, the pus on the tonsils. It confirms the site of the infection.
you're building such a strong case just with clinical skills. But here's where it gets really interesting, because even with all those clues, our source material stresses the need for objective certainty. So now we get to dive into the definitive proof, the blood work.
Absolutely. The OPD tip in our source is crystal clear on this. It says you should always check a CBC, a complete blood count, and a CRP, which is C-reactive protein, before starting antibiotics.
No guessing.
No guessing. You have to back up your suspicion with hard data.
Okay, let's break down that CBC, specifically the white blood cell count, the WBCs. The body's army, how does a viral army look different from a bacterial one?
In a viral attack, the body's response is often a bit more subtle. The total WBC count might be normal or sometimes even a little low, but the key is the composition. You see an increase in a specific type of cell, the lymphocytes.
And they're the virus specialists.
Exactly. Their numbers go up. It confirms a viral battle is underway.
But a bacterial infection, that's a different kind of war. It needs a bigger, faster response.
It does, and this is where we get really quantitative. With a bacterial infection, the total WBC count is high. The source gives a clear cutoff. A WBC count over 11,000 is a big red flag.
Over 11,000.
And it's not the lymphocytes that are rising, it's the neutrophils.
Yeah.
You get a high neutrophil count, and often you see something called a left shift.
Okay, let's unpack that. Left shift sounds like pure medical jargon. What does it actually mean?
It's a great question. A left shift means the body is in such desperate need of neutrophils that the bone marrow is pushing them out before they're even fully mature.
Wow.
Think of it like sending raw recruits to the front lines. Because the battle is that intense, you just need bodies. That left shift is a powerful sign of a severe acute bacterial infection.
So that 11,000 number and the left shift give us half the story, but now we move from the cells to the chemical messengers, the inflammatory proteins.
Right, and there are two key markers to watch here: CRP, C-reactive protein, and Procalcitonin.
Okay, let's start with CRP. What's the clean numerical distinction?
So CRP measures general inflammation. In a viral fever, it'll be only mildly raised. The guide says generally below 30 milligrams per liter. It's like a low-grade alarm.
But if it's bacterial.
It's markedly raised, greater than 30 milligrams per liter. That jump is often a really clear sign of the infection's nature and severity.
And then there's procalcitonin. The guide seems to position this as the sort of knockout punch, the most definitive marker.
It's fascinating because it is so incredibly sensitive to bacterial toxins.
Yeah.
In a viral fever, the levels are almost nothing. They stay very, very low, less than 0.5 nanograms per milliliter.
Barely a blip on the radar.
Exactly. But if that fever is bacterial,
The levels explode.
they explode. The guide points to levels greater than 2 nanograms per milliliter. I mean, think about that jump. It's a 4-fold difference or more. It provides this crystal clear objective certainty.
And this all connects right back to you listening at home. Understanding these numbers shows you why a simple temperature check isn't enough. The real decider is your body's internal inflammatory response, measured by these markers.
Which brings us to the ultimate so what of all of this, which is treatment.
Right.
The paths could not be more different. For a viral fever, treatment is purely symptomatic. Rest, fluids, paracetamol to feel more comfortable. You're just supporting your immune system while it does the work. For bacterial infection, you have to intervene. You need antibiotics, plus that same supportive care.
And this is where the guide offers some really critical advice on timing and, frankly, restraint. It says very clearly to avoid empirical antibiotics in mild, self-limiting viral fevers.
Don't treat a suspicion. Treat a diagnosis. And if there's any doubt, let's say the labs are borderline, the WBC is 10,500, not quite 11,000.
What do you do?
The recommendation is clear. You wait 24 to 48 hours, continue with symptomatic care, and then you reassess. Patience is a clinical tool. It lets the body declare itself before you commit to a powerful drug.
And the final piece of the puzzle is actually the response to the treatment itself.
Precisely. If you start someone on antibiotics and it was actually a virus, they won't get better. After 48 or 72 hours, there's no improvement.
Which confirms the drug was unnecessary.
Right. But if it was bacterial and you chose the right antibiotic, you should see significant improvement in that same 48 to 72-hour window. It confirms the diagnosis after the fact.
So testing, waiting, and then observing the response, those are the key strategies. So what does this all mean? It means diagnosing what seems like a simple fever is actually the sophisticated step-by-step process of elimination. It's all based on clear, quantifiable data, from how it started to a doctor's physical exam, all the way to the precise threshold of a protein like procalcitonin. We've moved completely past guesswork.
That's the takeaway. These clinical guides show that good medicine is a synthesis of subjective observation spotting, that toxic look, and hard, objective data, like a WBC over 11,000. And maybe the biggest decision a clinician makes isn't which antibiotic to use, but exercising the discipline to know whether to use one at all.
That balance between action and caution is everything, and it makes you think. If we could remove some of that uncertainty, here's a final provocative thought for you to explore. Imagine a rapid, cheap, at-home test for procalcitonin. You could get that less than zero point 0.5 versus greater than 2 number instantly. How would that single piece of data change that 24 to 48-hour waiting period? And could it perhaps completely shift the global approach to early and responsible antibiotic use? Something to mull over until our next deep dive.